Good afternoon. I think we are going to start with all our speakers, but we just have a small request. Dr. Vineet Shah has a flight to catch, so can we please let him go as the first speaker? I hope the first speaker wouldn't mind that. Uh, Vineet, we can take over with you so that you're ready to. I think after Vineet, we'll have Dr. Mariam Matthew. So Vineet is talking to us on presenting on a unique case of adult onset foveal vitelliform dystrophy with dry AMD.
Shall I start? Good afternoon, everyone. I'll be talking on a unique case of adult onset foveal vitelliform dystrophy with dry AMD features. So, 50 years old male presented to us with chief complaint of diminution of vision in 6 months in the both eyes. There was no history of any trauma or any systemic illness. On examination, his best corrected visual acuity was 6 by 18 in both eyes, and on anterior segment examination, it was normal. Whereas on fundus examination, the media was clear, and about 0.2 cup to disc ratio was seen with 2 by 3 AV ratio. But in the macular area, yellowish subretinal deposit of around 2 to 3 disc diameter in the crescenting shape was seen, along with drusenoid changes. So, on the basis of this, a differential diagnosis of best dystrophy with bilateral CMVM or adult onset foveal vitelliform dystrophy was made, and the patient was further investigated on fundus autofluorescence. As we can see here, there was hyper autofluorescence, and on OCT in the various sections shows cavitation along with subretinal hyperreflective material with drusenoid PEDs. Similar features were seen in the left eye. Octa was done in both the eyes, which did not show any presence of network, so the CNVM was ruled out, and then electrocardiogram showed the normal adherence ratio, so best disease was ruled out. So the diagnosis of adult onset foveal vitelliform dystrophy along with dry AMD features was made. So what is AOFVD? It is a rare disease affecting the macula. It was first described by Gass in 1974. Basic genes which are involved are PHH2, BEST1, IMPG1 and IMPG2 genes, and onset is between third and fifth decade. Features are about half to one-third this diameter, subretinal yellowish lesion can be seen around the macula. In fluorescence angiography early stage, there is hyperfluorescence surrounding hyperfluorescence, and the late stage similar leakage staining is seen. Fundus autofluorescence shows central hyperautofluorescence surrounded by hypoautofluorescence, and OCT shows a homogeneous subretinal hyperreflectivity material below the RPE. So, what are the differential diagnoses? First is the adult onset foveal deafness, which is seen in around 40 years, and EOG is usually normal in these cases. Other is the best vitelliform macular dystrophy, which is usually seen in childhood, and the EOG marker is abnormal. Other conditions such as autosomal recessive Best retinopathy, in which EOG markedly abnormal and hyperopia is usually seen. And in CNVM, it is usually seen in above 60, and there will be leakage in fluorescence angiography. And in paraneoplastic vitelliform retinopathy, ERG and EOG will be abnormal, and anti-RP antibodies can be seen. So coming to the treatment, there is no usual treatment available. Gene therapy is a formatting future option coming up. If CNVM develops as a complication, anti-VEGFs can be given. So, just to summarize, AOFAD is a rare macular condition that usually results in slow progressive bilateral vision loss. Clinical appearance is bilateral, usually symmetrical, 1/3 to half disc diameter in size, round to oval. Age is around 30 to 50 years of age, equal sex predilection and autosomal dominance in nature. Fundus angiography shows central hypo surrounding a ring of hyperfluorescence, and EOG may be slightly subnormal but usually is normal in most of the cases, and OCT shows a hyperreflectivity below the RPE. Complications seen are CNVM and full thickness macular hole, and in these such cases, 6 monthly comprehensive eye checkup is required for the patient along with family members, and low vision aids can be described. Thank you.
Thank you, Vineet.
Thank you.
Do we need to
No, we just have to
mark it?
Sure.
We can, in case you have something specific.
We just mark.
So we have the second speaker now, Dr. Mariam Matthew.
Good morning, respected chairpersons. So I'll be presenting a case of atypical weak age disease in which multimodal imaging techniques played an important role in the diagnosis and management of this disease. Weak age disease is a granulomatous inflammatory disorder affecting the eyes, auditory system, meninges, and skin. It's an autoimmune inflammatory condition mediated by T cells that target melanocytes in individuals who are susceptible to the disease. And it causes severe bilateral intraocular inflammation associated with serous RDs, edema of the disc, vitritis, with the eventual development of a sunset glow fundus. Commonly seen in Hispanics, Native Americans, and Asian Indians. There is a slight female preponderance, and it's seen commonly in the 2nd to 5th decade of life. Our patient is a 15-year-old boy who presented to us with blurring of vision in his left eye of 1 day and right eye of 4 days duration. There was no relevant past history of any redness, pain, photophobia, any fever or any rashes, any history of drug intake or surgery or any trauma or systemic illness. Patient was preparing for his board exams and he was basically studying too much into the late hours of the night. On examination, his visual acuity in the right eye was 6 by, counting fingers at 3 meters, improving to 6 by 36 and with pinhole, and his near vision was only n by 36. Left eye 6 by 36, improving to 6 by 12. Anterior segment was within normal limits. No signs of uveitis was there. The fundus in the right eye showed a hyperemic optic disc with multiple pockets of SRF in the peripapillary and foveal region extending temporal to the fovea. RPE changes were seen in a serpiginous manner around the pockets of SRF. And the left eye showed hyperemia of the optic disc with pockets of SRF in the macular region. This is a fundus picture. Autofluorescence showed hyperfluorescence in the areas of SRF, and RPE changes were seen in a serpiginous manner around the pockets of the SRF. Both blue and infrared autofluorescence showed changes. FFA and ICGA in the early phase showed pinpoint leaks with multiple hyperfluorescent areas. In the later frames, multiple hyperfluorescent plaques and pooling of the dye was seen in the SRF pockets, and disc hyperfluorescence was seen on the FFA. This is a left eye picture showing pinpoint leaks and areas of hyperfluorescence in the areas of SRF and diffuse choroidal hyperfluorescence in the late phase. OCT showed multiple pockets of SRF, subfoveal intraretinal fluid, and RPE alterations. Left eye in the right eye, and the left eye showed an SRF. There was bilateral diffuse thickening of the choroids. The foveal thickness in the right eye was 792 and left eye was 484. And SFCT in the right eye was 773 microns and 550 microns in the left eye. Based on the presence of multiple pockets of SRF, diffuse choroidal thickening on OCT, pinpoint leaks on FFA, and hyperfluorescent plaques in the later phase on FFA, and a diagnosis of probable weak age disease was made. After doing the basic blood investigations and with physician's concurrence, patient was started on intravenous methylprednisolone 1 gram daily for 3 days, followed by oral prednisolone in a dose of 80 milligram per day, which was tapered by 10 milligram weekly. After 1 week, his visual acuity was improved to 6 by 9 in both eyes, and OCT showed a reduction in the foveal thickness to 253 and 257 microns in right and left eye. SFCT also reduced to 346 and 425 microns. There was resolution of SRF pockets also. After 1 week, the patient was started on immunosuppressants, that is tablet MMF, 1000 milligrams, because early institution of immunosuppressants is important in the prevention of relapse of the disease in the later stages. Patient was the prednisolone was tapered by 10 milligram weekly, and on follow-up after 6 months, his visual acuity was restored to 6 by 6 in the right eye and 6 by 6 parts in the left eye. There was complete resolution of SRF in both eyes, and he was maintained on a low dose of prednisolone, 5 milligram OD, and MMF was maintained at 250 milligram twice daily with monthly monitoring of blood counts and LFTs. This is a fundus picture that was seen after 6 months. It's totally showing a normal fundus.
We can just finish it.
Okay.
You can tell.
So basically, I'll just, the critical take-home points is, though classically Vikesh disease is a multi-system disease, many patients fail to develop the complete or incomplete forms. And clinical diagnosis is aided by the help of multimodal imaging techniques like the FFA, ICGA, and OCT. And delay in the correct diagnosis and initiation of an appropriate treatment can result in the disease entering the chronic or the recurrent phase, and in the subsequent development of complications like glaucoma, cataract, and subretinal neovascularization or fibrosis. Early diagnosis and prompt and adequate treatment with immunosuppressive agents may halt disease progression and prevent recurrences and vision loss. These are the references. Thank you.
Thank you. The next speaker is Deepyan Sarkar.
दीपान सरकार ऊपर ये वाला दीपान सरकार सरकार जो है ना इसके नीचे हाँ ये तो दीपान हाँ Respected judges, faculties and my dear friends, a very good afternoon to you all. The topic for my today's session is a case of endogenous and endophthalmitis masquerading as Behçet's disease, a diagnostic dilemma. A 24-year male attended the outpatient department with chief complaints of redness and dimness of vision in the right eye since last 10 days, with mucosal lesions over the hard palate, inner surface of the lips and over the glans penis. There was a history of long-standing pain of the knee. The vision in the right eye was hand movement close to face with intact projection of the rays. In the left eye it was 6-6. The adnexa was normal. The anterior segment showed circumciliary congestion, 2+ cells and flare in the anterior chamber. There was pigment dispersion over the lens. The IOP by Goldman applanation was 12 mm of Hg. The angles were open on gonioscopy. On fundus examination, there is a pale yellowish glow of the fundus. These are the vitreous bands which were found in the anterior and the mid-vitreous. There was grade 4 media haze with no view of the fundus details. The optic disc blood vessels and blood vessels were not visible. The left eye had normal findings. On systemic examination, there were multiple painless ulcers which were present on the hard palate, which were present on the inner surface of the lips and the glans penis. These were present since last 6 days. USG B scan was performed. It shows dense vitritis in the central and the posterior vitreous. No evidence of posterior vitreous detachment. Blood investigation revealed eosinophilia. The other blood investigations done were within normal limits. So on this grounds, multidepartmental consultation was done and diagnosis of Behçet's disease was made. The patient was initially started on oral and topical steroids and cycloplegic. But the patient became febrile on the second day of treatment and the blood work showed marginally raised WBC count with eosinophilia. The steroids were withheld and blood culture was performed which showed the presence of Spingomonas possimobilis, which is a rare organism. The repeat urine culture was sterile, but the USG KUB done showed presence of free-floating membranes in the urinary bladder, which was suggestive of subclinical subacute cystitis. There was a revised diagnosis of endogenous ENDOPH in this patient with the principal focus of infection was cystitis. Drug reaction to the NSAIDs prescribed for the musculoskeletal pain of the knee led to the painless actus ulcers. The patient was given an intravitreal injection of ceftazidime, vancomycin and dexamethasone. The vitreous trap yielded dry. The patient was also started on systemic fluoroquinolones and tinidazole. As per culture sensitivity, topical steroids and other supportive medications were also started. The patient was also started on systemic steroids after 5 days of the oral medications when he was relieved of his systemic symptoms of fever. This treatment yielded favorable results with the patient gaining a vision of 624 in the right eye after 3 weeks. At 5 weeks, the vision was 618. As you can see, the vitreous haze is now 2+. You can see the optic disc, blood vessels can be faintly seen. There is no evidence of vascular sheathing, vascular or vasculitis. The OCT angiography also showed no vasculitis changes in the right eye. The take-home message is Behçet's and Endoph have a similar clinical profile, making it a difficult clinical diagnosis. Endophthalmitis is an ophthalmological emergency which requires prompt diagnosis and management for better outcomes. Failure to do so can lead to vision-threatening complications, which can eventually require evisceration. Endogenous endophthalmitis, having no specific clinical feature, no diagnostic laboratory test, is often missed on initial examination, and it becomes all the more important for an ophthalmologist to keep endogenous endophthalmitis as a probable diagnosis in a case of panuveitis in an immunocompetent young patient, even with no active systemic disease or complaints. Thank you.
But yeah, the next speaker will be Harish Kumar. Harish Kumar is here. Then Anuradha, Dr. Anuradha. Yeah.
Till Dr. Anuradha is presenting her case on central serous chorioretinopathy following an episode of angioedema, I'm going to ask Dr. Sarkar, why OCT angiography?
OCT angiography was done, it was not required for the diagnosis, but it was done to show it is not an Behçet's disease, because once we have ruled out, and also we did not have a vitreous cap in this patient. So ma'am, if the patient had an Behçet's disease, the OCT angiography would have shown a dropout of the vascularity in the superficial and the deep layer, but there was no such changes. So this diagnosis was just for the presentation purpose, to rule out any Behçet's.
Okay. We'll concentrate on.
You said, sorry, just a quick question. You said NACID is led to the aphthous ulcers. How do you explain ulcers on the other parts of the body then?
Ma'am, all the ulcers were of the mucosal lesions of the mucosa. So all were the aphthous ulcers, which were mainly the ulcers when the patient presented were painless ulcers, which is in contrary of what we find in Behçet's. But in a multi-departmental consultation, dermatology told us this can be an atypical presentation. So we went with the diagnosis of Behçet's because all the other things were in accordance with Behçet's. But later when we found out the sphingomyelin in the blood work of the patient, then they reviewed the diagnosis and they told this is an aphthous ulcer, and the patient history was also reviewed. It was found patient was taking NSAIDs that had caused the aphthous ulcers.
Okay.
A very good afternoon. Central serous chorioretinopathy, or CSCR as we all know, is an exudative retinal detachment at the posterior pole, predominantly affecting middle-aged males. Though it is known that the disease is caused due to an abnormality in the RPA pump mechanism, but the etiopathogenesis of the disease is still under investigation. Most of the cases are idiopathic and there are multiple hypothesized etiologies. Today I shall be presenting a case of CSCR which the patient developed after an episode of angioedema. This is a kind of a case that has not been previously reported. A 37-year-old male was referred to us from medicine department with a history of sudden paleness, diminution of vision of the left eye. He gave a history of developing angioedema 2 days prior, which was managed with a single dose of corticosteroid and antihistamine, followed by oral antihistamines for 2 days, with which he had resolution of symptoms. At presentation, the patient was stable. The right eye examination was unremarkable, except for a finding of a cup-disc ratio of 0.7:1 with a healthy neuroretinal rim. The vision in the left eye was 6/18 parts with no further improvement. On anterior segment exam, we discovered a wedge-shaped lenticular opacity in the nasal quadrant. The cup-disc ratio in this eye also was 0.7:1 with a healthy neuroretinal rim. And the posterior poles showed a 1.5 disc diameter size detachment of the neurosensory retina with clear subretinal fluid at the macula. The IOP of this patient was normal. These are the pictures, initial pictures of the patient, the color fundus and the red tree picture. The OCT of the right eye, OCT macula of the right eye was within normal limits, and the left eye showed a characteristic dome-shaped elevation subfoveally. The central macular thickness at this point was 629 microns. The fundus fluoris angiogram showed a pooling of dye in characteristic ink blot pattern in the left eye. These are the pictures, initial pictures of the patient. So with the clinical presentation and initial investigations, we came to the diagnosis of CSCR left eye. And since this was the first episode, we took the course, conservative course, and we decided to observe the patient for spontaneous resolution of fluid. But over a period of 3 months, the patient did not have complete resolution of fluid, so he was started on tablet eplerenone, 50 milligrams OD, after systemic workup and counseling of the patient regarding the adverse effects. We gave the treatment for 6 weeks, during which we saw a resolution of SRF, which continued over the next 3 months, finally leading to complete resolution of SRF. OCT macula also showed signs of chronicity initially in the middle part of the treatment, and followed by complete resorption of fluid. So these are the progressive OCTs. The first one is at presentation. The second one is at 3 months of treatment, where we can see a shallow SRF and subfoveal hyperreflectivity. And the final OCT is complete resolution of fluid, but the foveal thickness has come down. So the present status of the patient is the vision is 6 parts. There is some residual metamorphopsia. Patient is presently not on any drug and has not reported any recurrence of the symptoms. In view of the increased cup disc ratio, we also took up a glaucoma workup concurrently, which was unremarkable. And the cataract that we discovered in the left eye was did not progress with time. This is the glaucoma workup that we did. The OCT RNFL showed an increased cup disc ratio, but the NRR, as we can see, is normal. The right eye visual field was normal. The left eye showed a central scotoma, which is consistent with CSR. CSCR and exudative retinal detachment, the causes are largely idiopathic. There are many etiological factors which have been hypothesized, most importantly chronic exogenous or endogenous steroids and other drugs like antihistamines or proton pump inhibitors, GERD, pregnancy, H. pylori. But still the causes are under investigation. Under research. The patient characteristically presents with diminution of vision central scotoma with metamorphopsia and micropsia, which was the characteristic presentation in our patient also. Multiple modalities of treatment have also been suggested, including medical management with eplerenone and other drugs like rifampicin, finasteride, mifepristone, and laser therapy, micropulse laser, photodynamic therapy. Also intravitreal anti-VEGF, but observation still remains the first line of treatment. So why was our case unique? First of all, even though we know that chronic steroid and antihistamines have been reported as rheological agents, and in an hyperacute setting where there has been a single dose of steroid administered, we have not seen any such cases. During our research, we did come across one case report of CSCR happening in a patient with non-histaminergic angioedema who was on steroids in tapering doses. But our patient had responded to antihistamine and he was not on any long-term steroids. Regarding cataract, I came across a research with 2 patients developing cataract on chronic antihistamine therapy. But again, this was not the case in our patient, so we regarded the cataract as an incidental finding. This is the first case of CSCR, which was reported after an episode of angioedema, which was responsive to antihistamine, and there was no history of chronic drug intake. To conclude, CSCR is a very common yet still mysterious disorder, which is still under research. And chronic endogenous or exogenous steroids have been associated with CSCR, but angioedema as yet has not been reported as a causative agent. Also, in this circumstance, the role of endogenous steroid response and external administration of drugs such as steroids and antihistamines in a hyperacute setting need to be explored as a cause of CSCR. These are my references. Thank you.
We'll call next speaker Dr. Deepak Chaudhary. He has a flight, so last one.
Deepak, front row, sir.
Good afternoon, everyone. Today I am going to present vitreous hemorrhage, ultrasonographic and clinical findings comparison. I have no financial disclosure. Introduction. The incidence of spontaneous vitreous hemorrhage is approximately 7 cases per 1 lakh population. It can be caused by pathologic mechanisms of disruption of normal vessels. In diseases like diabetic retinopathy, vitreous hemorrhage is also common. In following trauma, there may be retinal holes may be present or retinal detachment may be present. Then unique clinical pathology features of long-standing vitreous hemorrhage include cholesterolosis bulbi, there is syncytial scintillans, and vitreous cylinders. The complications of non-clearing vitreous hemorrhages are hemosiderosis bulbi and glaucoma. So prompt evaluation is required and necessary adequate treatment is required. The aim of our study is to find various causes of vitreous hemorrhage and to compare clinical findings with ultrasonographical findings. Materials and methods. It is a prospective type of study including 17 patients done between July 2020 to June 2021. All patients with vitreous hemorrhage were included in this study. Both A scan and B scan was done and the patients were followed up. The various ultrasonographic findings like retinal detachment, retinal tear, intraocular foreign body, posterior vitreous detachment, choroidal detachment, all were recorded. And these records are compared after intervention or after resorption of the vitreous hemorrhage. The age group was 22 to 77 with mean age of 57 plus 13.2. The male is to female ratio was 1.7 to 1, and in 40% of cases vitreous hemorrhage was due to diabetic retinopathy, and in 36% it was due to trauma. In 4 patients RD was seen in ultrasound, but originally 3 patients had retinal detachment, so the accuracy was 75%. And out of 3 patients with retinal break detected ultrasonographically, only 1 had retinal tear. So the detection of break is poor, that is 33%. And other cases without retinal involvement attained better visual acuity after resolution. This is a picture, vitreous hemorrhage with RD and without RD. Discussion. Christoph et al. They found proliferative diabetic retinopathy was most commonly present in patients with vitreous hemorrhage, 32%. Retinal tear was present 30% of cases. And proliferative retinopathy associated with retinal vein occlusion was seen in 11% of cases. Rabinowitz et al. He found the sensitivity of ultrasound B scan was 100% for RD and 92% for choroidal detachment, and 44% for retinal tear and 100% for IOB. In a study, we cannot detect retinal tear very accurately. Conclusion is ultrasonography you can accurately predict the retinal detachment in vitreous hemorrhage cases, but retinal tear detection and localization is poor. Thank you.
Yeah. Thank you. We'll invite our next speaker, Dr. Neelam Khatwani.
Good afternoon, everyone. I'm going to present a study on clinical profile and distribution of peripheral retinal changes in myopic population in North India. Increased prevalence of myopia is a growing concern, and it is estimated that it will reach till 49.8% by 2050, as it's depicted in this graph. And it's associated with increased prevalence of peripheral retinal degenerations also, which can be innocuous or can predispose to certain visual threatening complications like retinal detachment. So the aim of my study was to evaluate the prevalence of different types of peripheral retinal changes in myopic population of different age groups and sex. The objectives were to document the type of peripheral retinal degeneration and its fundus location in different age group and sex, and also to record the axial length. It was a cross-sectional study in which 600 eyes of 300 myopic individuals of 10 to 40 years were included. They were divided into 3 age groups, and the myopia was divided into mild, moderate, high, and severe myopia. The routine visual assessment and ophthalmic examination was done, including the binocular indirect ophthalmoscopy with scleral indentation. The findings considered were lattice degeneration, white without pressure, white with pressure, snail tract degenerations, peripheral chorioretinal atrophic changes, retinal holes, tears, detachment, and they were subcharacterized by the fundus location. The results, any type of peripheral retinal degeneration was found in almost half, that is 53% of all the myopes included in my study. Lattice degeneration was the most common finding, followed by white without pressure and chorioretinal atrophic changes, and they were situated mostly in the temporal, either infratemporal or supratemporal quadrant of the fundus. A positive association was seen with increased spherical equivalent of refraction and axial length also. Coming to the discussion on comparison of our result with other studies, ours was an observational hospital-based cross-sectional study as compared to the previous studies, which were also mostly cross-sectional studies. Ethnicity, different type of ethnic origin people had different type of results. Like in a study, it was found that Indians have a lower incidence of retinal detachment than Caucasians, which was done by Elneri et al. Similarly, age had a positive association in most of the studies, like in Beijing eye study, Shilpai eye study. Gender doesn't had any significant role. This is a table in which our study was compared with the previously done studies. Similarly, the axial length was found to have a positive association, even the severity of myopia and fundus location. Similar to our study also, most common fundus location was either infratemporal or supratemporal quadrant of fundus. Coming to the strengths of the study, in this study, myopic population of all the grades and severity was included, rather than including only high or pathological myopia as it was done in most of the previous studies. A wide age group ranging from 10 to 40 years, which included children as well as young adult of both the sexes, provided a better and detailed analysis. Certain limitations were there. It was a limited sample size, and it was a hospital-based study in which only those patients who had come to the hospital for some vision-related problem were included. Use of data from 10 to 40 years age group does not give insights on overall proportion of myopic lesions in elderly population, as it was found that certain lesions like chorioretinal atrophic changes are more common in elderly age group. Then PVD, it develops at a significant younger age in highly myopic eyes, which can explain the early occurrence of PVD-related peripheral retinal changes in highly myopic patients. The documentation of PVD by OCT could have given an extra edge to our study. So the take-home message is, any ophthalmic examination without a careful peripheral fundus examination is incomplete. So peripheral fundus examination is a must, particularly in myopic patients. And the documentation of axial length should also be done, as it can help us to evaluate the early detection of progressive myopia also. Thank you.
Thank you. Next speaker will be Dr. Neelam Sadhwani.
कौन सा है वो मैं चेंज कर दूँ इसमें कौन सा है? हाँ लास्ट ये वाला हाँ वो मैं चेंज कर दूँ
Shall I start? Very good afternoon. So my topic for today is outcomes of vitrectomy.
Just hold on, it's not started. Excuse me. Excuse me from the IT team. Yeah. Presentation now starting on the screen.
Start. Very good afternoon to all of you. So my topic for today is outcomes of vitrectomy with internal limiting membrane peeling in eyes with persistent chronic macular edema. We do not have any financial interests. The rationale behind the study was macular edema is a very common and significant risk factor for visual loss in diabetic retinopathy, vascular occlusions, and uveitis cases. Currently, antivascular endothelial growth factors, anti-VEGFs, drugs are considered as the first line of treatment for macular edema. However, due to short duration of action and need for multiple injections and monitoring visits are required, so these result into financial burden on the patients. Also, the previous report suggests that in spite of anti-VEGF injections for 6 consecutive months, up to 60% of the eyes still had persistent DME. PPV in cases with chronic macular edema reduces the traction by removing the posterior hyaloid, epiretinal membrane, and the internal limiting membrane. Pars plana vitrectomy with ILM peeling can be considered as an alternative treatment for chronic macular edemas. Aim of the study was to evaluate the results of pars plana vitrectomy with ILM peeling in eyes with persistent chronic macular edema. Methods: a retrospective case series where patients with persistent chronic macular edema who were treated with PPV with ILM peeling due to unresponsiveness to more than 4 intravitreal injections of either anti-VEGF or steroids were included. Subjects with a previous history of vitreoretinal surgery, grid laser for macular edema, and oral steroids were excluded from the study. Best corrected visual acuity and central macular thickness were noted pre and post PPV with ILM peeling. The results were 6 eyes of 6 patients were included in the study. Improvement in BCVA was noted in 5 out of 6 cases. Clinically significant reduction was noted in macular thickness in all of the cases. However, no statistical significance could be achieved because of the small case study size, and there was too much variation between the macular thickness pre and post-op. These are the pre and post-op images, OCT images with visual acuity of the patients. As you can see, all 6 had an improvement in the corneal thickness, central macular thickness, and visual acuity also improved in 5 out of the 6 patients. So the discussion comes, the possible mechanism includes ILM peeling reduces the epiretinal membrane formation further, which may be associated with a recurrence in macular edema. And it also removes the barrier between the retina and vitreous, thereby increasing the diffusion of large molecules from the retinal tissue into the vitreous cavity, thus resulting in a reduction in intraretinal osmotic pressure and elimination of water from the retina. ILM peeling also increases the oxygen diffusion from ciliary body to retina and improves the oxygen supply to retina. Pars plana vitrectomy may also remove some cytokines and inflammatory mediators within the vitreous, which causes leakage of the retinal vessels, and thus may also contribute to the reduction of macular edema. So concluding, pars plana vitrectomy with ILM peeling showed clinically significant reduction in macular edema in all of our cases. Reduction in macular edema post pars plana vitrectomy with ILM peeling could have a positive impact on the individual quality of life, reducing their cost, financial cost, and frequent visits to the clinics. These are the references. Thank you.
Did you, at the end of surgery, was any anti-VEGF or steroid given?
No.
And what was your criteria for non-response to anti-VEGF?
Ma'am, there was no significant decrease in the macular thickness or visual acuity after 4 injections. Monthly intervals, ma'am.
So, did you change following the 3rd injection? There was no switching of the drug?
Sir, after the 2nd and 3rd injection, we tried combining the injections with steroids, like steroid and anti-VEGF combined injections.
pre-surgery, did you give any specific anti-VEGF before you did the surgery?
No, the patients didn't have any history of previous anti-VEGFs given when they came to us.
And out of your 6 patients, the third number patient and the 5th number patient had already associated epiretinal membrane and a vitromacular traction. So they were not like like classic chronic macular edemas without any other cause. So
You can have a confounding,
yeah.
Thank you.
Thank you, ma'am.
We have next speaker, Dr. Raminder Singh. Dr. Ravinder Singh is here. Dr. Pooja Kothari. Dr. Pooja Kothari. Dr. Sonali.
Second.
No.
Yes. Good afternoon, everyone. Today I am going to present the case of retinal artery macroaneurysm, an uncommon manifestation of radiation retinopathy. So, a 33-year-old male presented with sudden painless diminution of vision in the right eye since 2 days. He had history of radiotherapy to the right side of the skull 17 years before for brain tumor, and which was in a complete remission now. He had no history of any systemic illness. On external examination, it showed right temporalis muscle atrophy. On ocular examination, his best corrected visual acuity was 6/36 in the right eye and 6/6 in the left eye. Anterior segment examination of the right eye showed punctate epithelial erosions, corneal filaments. Shermer test was 7, and it showed posterior chamber intraocular lens, and fundus showed vitreous and pre-retinal hemorrhages obscuring the fundus view. Left eye ocular examination was within normal limit. So at this point, we advise patient to maintain the restricted activity and review after 2 weeks. So 2 weeks after presentation, right eye showed regressed vitreous hemorrhage. There were subretinal hard exudates along the superior-temporal arcade. Left eye was normal. The fundus fluorescein angiography of the right eye showed microaneurysms over the posterior pole with the leakage of dye along the superior-temporal arcade, likely RAM. And OCT, we did the OCTA to rule out any neovascularization. OCT showed presence of pre-retinal hemorrhage, which was obscuring the retinal details. At this point, we gave intravitreal anti-VEGFs to the patient, and 1 month post-injection, his visual acuity improved to the 6/6, and fundus showed resolved vitreous and pre-retinal hemorrhage. And OCT, we can see a round cavity with hyperreflective wall and a dark lumen suggestive of RAM. So probably that vitreous hemorrhage was secondary to the RAM. So the second, in case 2, a 67-year-old male came for routine examination. He had history of intravenous chemotherapy and radiotherapy to the right side of the neck 6 years back. He had no history of any systemic illness. On external examination of face, it showed torticollis and neck stiffness. His best corrected visual acuity was 6/9 in the right eye and 6/6 in the left eye. Anterior segment examination of both eye were normal. So on fundus examination, right eye showed microaneurysms over the posterior pole, left eye was normal. FFA of the right eye showed microaneurysms over the posterior pole, multiple CNP areas in the periphery, left eye was normal. At this point, we advised sectoral laser to the CNP areas. Then patient lost to follow-up, and he presented 1 year later with diminution of vision in the right eye since 2 months. On ocular examination, his BCVA was 6/60 in the right eye and 6/6 in the left eye. Anterior segment examination of the right eye showed NS2 cataract. Fundus showed retinal artery macroaneurysm along the superior-temporal arcade with subhyaloid and subretinal hemorrhage. And peripheral retina showed laser scar. Left eye was normal. This is the fundus photo showing subhyaloid hemorrhage. So OCT showed pre-retinal hemorrhage, and there were intraretinal hyperreflectivity along the superior temporal vessel suggestive of RAM. So at this point, we have advised phaco with vitrectomy along with the intravitreal anti-VEGFs. 1 month post-surgery, patient showed cystoid macular edema and RAM with minimal SRF. So at this point, we have advised intravitreal triamcinolone, and after triamcinolone, at this point, we advise triamcinolone along with the focal laser to the RAM. So after 1 month of IVTA and focal laser, OCT showed resolved CME. So radiation retinopathy is a frequently encountered complication of radiotherapy for ocular and periorbital cancer. It is influenced by the dose, duration of treatment and concomitant systemic factors. Intracranial aneurysms following radiotherapy for the head and neck cancer has been reported, but retinal artery macroaneurysm after radiation retinopathy has never, but RAM in a retinopathy has never been reported before. In our case, patients with history of radiotherapy, clinical and imaging characteristics in the absence of any systemic illness rendered RAM secondary to the radiation a likely diagnosis. Treatment of RAM include laser photocoagulation, intravitreal anti-VEGFs and PPV. Thank you.
Thank you. Next speaker will be Dr. Kirti Kumar. Dr. Kirti Kumar. The next speaker will be Dr. Khushbu Somani. Kirti Kumar. Yeah, sure.
Good morning, everyone. Today I'm presenting a case report, the 3S in a patient with chronic serous chorioretinopathy. Central serous chorioretinopathy is characterized by serous detachment of the neurosensory retina and or the retinal pigment epithelium. It is due to leakage of vascular fluid through a focal leak in the retinal pigment epithelium into the subretinal space due to choroidal vessel hyperpermeability. Risk factors include type A personality, pregnancy, and systemic corticosteroids. A 42-year-old female presented to our OPD with complaints of a diminution of vision in her right eye since 45 days. The patient was also a known case of a systemic lupus erythematosus on systemic steroids from the past 10 years. On examination, her visual acuity in the right eye was counting finger 3 meters and left eye was 6 by 6. The rest of the anterior segment evaluation revealed signs of dry eye. Fundus examination was revealed a neurosensory detachment and loss of foveal reflex in the right eye, approximately about 2 disc diameters area, and the left eye was essentially normal. Sturm's test was positive and T-BUT was 9 seconds both eyes. Fundus examination and OCT revealed CSCR. Our central subfoveal thickness was 6 and 6 on microns on presentation. Since steroids was one of the risk factors for developing CSCR, we advised the patient to cut down on steroids and we referred her back to our rheumatologist for discontinuation of oral steroids. However, due to her underlying lupus nephritis, the patient was advised to continue a low dose of steroids. Her dosage was tapered from her initial 40 milligrams per day to 20 milligrams per day by her rheumatologist. Because the patient was on steroids, we decided not to wait and to start on some therapy. So we started on a topical Nepafenac 0.1% TID and advised to continue for 1 month. And we also advised treatment for the dry eyes. And the patient was followed up every 15 days. During the first and second follow-up, we saw no improvement in her clinical presentation or in any OCD changes in the CSCR. There was no improvement in clinical condition of the patient. So the patient was noted to have deranged renal functions with hypokalemia at the time of follow-ups. Hence, we started the patient on spironolactone 50 milligram OD in consultation with a physician and rheumatologist. The patient was further followed up every 2 weeks. In the third and the fourth follow-up, we saw some resolution of CSCR, and by the fifth follow-up, there was a complete resolution of CSCR. Serial follow-ups revealed resolution of CSCR and improvement of vision. The patient attained a final BCVA of 6 by 9 in her right eye over 1.5 months of therapy, and spironolactone was tapered and stopped. SLE, steroids, and spironolactone constitute the 3 Fs in our case. We conclude by saying that spironolactone therapy is an effective treatment for patients with CSCR on steroid usage for systemic diseases. Thank you.
Thank you. We'll invite Dr. Pranit Telukunda.
प्रेजेंट भी करना तो कर देता
Hello everyone. Today I would like to present a case report on retinal vasculitis with branch retinal vein occlusion post COVID-19 vaccination. We have no financial interests. We all know that SARS-CoV-2 has taken the world by its worst, and vaccination holds a key role in fighting the pandemic. All the vaccines authorized for emergency use have been carefully studied and found to be safe and effective in preventing severe COVID-19 cases. Though a few ocular side effects post-vaccination have been reported, the exact incidence is still unknown. Let us discuss the case now. I present a case of a 42-year-old female, homemaker by occupation, hailing from Telangana, presented to the OPD with chief complaints of sudden onset diminution of vision in the left eye since 2 days and also associated with appearance of black spots in front of the left eye since 2 days. The significant medical history which she had given was she had taken a first dose of COVID vaccine 10 days ago, and she was a hypertensive since 13 years on treatment, and she was well under control. On examination, the unaided visual acuity in the right eye was 660 improving to 6.6, and in the affected eye, that is the left eye, it was 2/60 not improving. The anterior segment was within normal limits. And the fundus of the right eye, we can see a large pre-retinal hemorrhage temporal to the macula. Apart from what is seen here, there were superficial hemorrhages in the superior temporal quadrant. In the left eye, the fundus showed superficial hemorrhages in the inferotemporal quadrant and also exudates along with it. So it could be a differential of IT-BRVO and also along with macular edema. So we came to a provisional diagnosis of right eye superior temporal BRVO with pre-retinal hemorrhage and left eye inferotemporal BRVO with macular edema. The FFA showed presence of focal leakages and block fluorescence temporal to the macula in the right eye and in focal leakages in the left eye, which confirmed vasculitis. OCT of the left eye showed gross macular edema. We investigated her further, and she came for a follow-up with the reports and found that all the investigations turned out to be normal. So we came to a diagnosis of right eye BRVO secondary to vasculitis and left eye BRVO with macular edema secondary to vasculitis post-COVID vaccination. In the right eye, we had administered injection bevacizumab, and in the left eye, injection Ozurdex. And she was asked to review after 2 weeks. The vision was same, and we had proceeded with a sectoral laser in both the eyes. 1 month post the laser, the vision improved in the left eye to 636 and N12. And 1 month post that, the vision improved to 624 and N12. The macula was dry, so we did not intervene any further, and we asked her to get back after a month. Now the discussion. COVID itself can cause ocular complications. Post-COVID vaccine reported complications include episcleritis, angioscleritis, acute macular neuroretinopathy, paracentral acute middle maculopathy, and subretinal fluid. A study by Sain S. et al. Hypothesized that the vasculitis found in post-COVID infection patients could be the same mechanism as that found in vasculitis post-COVID vaccination patients. There are reports of vasculitis post-COVID-19 vaccine which have been treated with oral prednisolone and recovered completely, but they have not mentioned the hypothesis for the same. In reports of retinal vein occlusions post-COVID vaccination, they have been treated with anti-VEGF, but only mild or partial improvement was seen in these cases. To conclude, our case report adds to further reports of possible side effects with potential serious post-immunization complications of COVID-19 vaccinations. Ophthalmologists should be aware of the possible rare ocular adverse effects after COVID-19 vaccination. Thank you.
Sure. Thank you. I will call Dr. Vaishakhi Prasanna.
Good afternoon, everybody. I'll be presenting a case of spontaneous closure of full thickness macular hole in a case of adult onset Coats retinopathy. Adult onset Coats retinopathy is different from childhood onset Coats disease due to its more posterior presentation, limited area of involvement, and hence a slower disease progression. The complications associated includes glaucoma, recurrent retinal detachment, epiretinal membrane, persistent macular edema, and rarely macular hole formation. With this, we'll see this case of 20-year-old male with no history of any comorbidities who presented with gradual diminution of vision in left eye since 1 month with a best corrected visual acuity of 20/50 and an unremarkable anterior segment examination. The fundus showed macular hole, which is more appreciated in this red-free fundus photograph, along with localized focus of multiple microaneurysms and surrounding area of hard exudates in a succinate pattern. Peripheral retina showed localized areas of telangiectasia along with perivascular exudates and few area of retinal collaterals. The optical coherence tomography showed presence of epiretinal membrane, full thickness macular hole along with cystoid macular edema. The right eye of the patient was within normal limits. With a diagnosis of adult onset Coats disease with full thickness macular hole with cystoid macular edema, the patient was given intravitreal injection bevacizumab. At 2 weeks, we could notice that there was closure of the macular hole, which was confirmed in the OCT, and there was presence of intraretinal as well as subretinal fluid. And hence, focal rays were given to the microaneurysms, followed by intravitreal bevacizumab injection at an interval of 2 weeks. 1 month post-injection, his visual acuity had improved to 20/20, along with closed macular hole and persistence of cystoid macular edema. At 2 weeks later, there was further deterioration of vision, and hence the patient was given intravitreal bevacizumab with triamcinolone acetonide, and 2 weeks later there was resolution of the subretinal fluid and substantial reduction in the intraretinal fluid also. The patient was also advised for further injection of intravitreal bevacizumab and triamcinolone acetonide, but since he denied injection, we kept him on regular follow-up with a stable vision till date. Full thickness macular hole is a rare complication associated with adult onset Coats disease, and the pathogenesis leading to that includes vitreous changes leading to vitreomacular traction, chronic macular leakage leading to macular edema and subsequent deroofing, reactive gliosis leading to epiretinal membrane formation and leading to tangential traction over the macula, leading to macular hole formation. Management in such case includes addressing all the pathogenic mechanism, which includes intravitreal anti-VEGF as well as steroid injection, and surgical management including pars plana vitrectomy, epiretinal membrane peeling, and internal limiting membrane peeling. And it is proven to give an excellent visual as well as anatomical recovery. Our case highlights spontaneous closure of full thickness macular hole in the setting of adult onset Coats retinopathy with intravitreal anti-VEGF alone. But nevertheless, the patient needs further follow-up to monitor the presence of cystoid macular edema as well as development of any complications such as exudative retinal detachment or glaucoma. Thank you.
Sure. Yeah, thank you. We'll invite Kevin Shaw.
Vaisakhi, at every OCT that you have shown, you have not shown from which area the OCT scan has been taken. And that also makes a lot of difference when you're taking the scans, okay, to exactly pinpoint that the macular hole is completely closed or not. So the scan picture from where you're taking the scan is extremely important.
Good afternoon. I want to like the case report on bilateral simultaneous central retinal vein occlusion in young patients. CRVO occurring commonly simultaneously both eye is a rare condition. Systemic vascular disease such as hypertension, diabetes are common risk factor for the development of CRVO that we already know. However, when a patient less than 50 years of age has bilateral and simultaneous CRVO, a hyperviscosity syndrome or inflammatory condition is also suspected. Retinal vascular disease occurs infrequently in young patients, and more than 90% of the cases occurs in people older than age of 50 years. Overall, only 10% of all CRVO patients are younger than 40 years of age. So the risk factors are associated with hyperviscosity syndrome due to hypercystinemia, malignant hypertension, chronic kidney disease, leukemia, multiple myeloma, and Waldenstrom macroglobulinemia. A 38-year-old male patient arrived in the retina clinic of Tejas Eye Hospital in the month of June 2021. The patient was having chief complaint of diminution of vision in both eye, right more than left, since 1 month. But actually the vision was same in the both eye. It was 460 on Snellen's chart, not improved with pinhole. Intraocular pressure of right eye was 11 mmHg and left eye was 12 mmHg. Anterior segment examination including the pupillary reaction was normal. The patient was having history of myocardial infarction 5 months ago and was treated with coronary angioplasty. The patient was also having diabetes and hypertension since 2 years. This is the fundus photograph. It shows simultaneous bilateral CRVO. This is the OCT of both the eyes, with around 450 thickness in both the eyes. The patient was investigated for CBC, ASR, RBS, lipid profile, urea, creatinine, homocysteine, and coagulation profile. The patient's homocysteine level was 55 micromoles per liter. The rest all reports were normal. The patient was started on folic acid, pyridoxine, and cyanocobalamin combination tablets and was advised intravitreal injection of bevacizumab after cardiologist clearance. Patient was not willing for ranibizumab injection due to financial issues. This is the cardiologist reports. After 1 month, the OD is showing resolving CRVO with note that there is significant disc pallor. OS is also resolving. So patient was advised the second dose of bevacizumab in both the eyes. And after the 2 doses, right eye CME was resolved, but left eye still is having CME. But the right eye IOP was 25 millimeter of mercury, so he was started on brimonidine plus timolol combination eye drops by glaucoma specialist. Right eye BCVA was 460, no improvement with pinhole. Left eye was 636 without improvement. So still the left eye CME was not resolved after the 3rd injection. So the patient was advised for left eye 2 milligram IVTA as patient was phakic. Ozodase option was given but patient refused due to financial constraints. This is the follow-up homocysteine level which was back to 20. So patient was simultaneously followed up regularly with cardiologist for control of systemic disease. After IVTA dose, left eye CME was not resolved and advised second dose of IVTA. And the repeat serum homocysteine, as we see, it is 15 micromole per liter. But patient's second dose is still due and patient has lost follow-up as of now. There are reports strongly indicating that hyperhomocysteinemia is an independent risk factor for CRVO. Homocysteine has been found to be associated with patients with a higher risk of thrombosis. There are various mechanisms which includes endothelial dysfunction due to hyperhomocysteinemia. Also include decreased bioavailability of nitric oxide, altered expression of various thrombotic factors, mitogenic effects on smooth muscle cell, and expression of acute stress-related genes. Keeping with other thrombophilic condition, hyperhomocysteinemia is a synergistic with other hereditary and acquired prothrombic disorders. Exposure of vascular smooth muscle cells in hyperhomocysteinemia can lead to upregulation of inflammatory response, which characterize early atherogenesis and may in part account for the adverse effect of high homocysteine. So conclusion is retinal vascular occlusion in young should be investigated throughout for embolic source and any disease causing thrombophilia as well as local ocular conditions. It is an established risk factor for hyperviscosity in young patient which leads to ocular as well as cardiovascular morbidities. Physician must be involved in comprehensive treatment of systemic disease. These are my references. There is no financial interest. Thank you.
Thank you. The next speaker will be Dr. Vishal Jadhav.
Good afternoon, one and all. I'll be presenting pressure downfall with a twist, a case on ocular decompression retinopathy after scleral fixated intraocular lens. Let's start with the background introduction first. So, ocular decompression retinopathy was first coined by Fechner et al. In 1992, wherein you can see multiple layered retinal hemorrhages due to an abrupt and iatrogenic fall in intraocular pressures in an eye previously having an high intraocular pressures. Basically, it usually occurs after glaucoma filtering surgeries, but there are a few case reports wherein these are condition can also occur in after posterior segment procedures as well. So keeping that background in mind, we'll just look at the case report. So this is a 17-year-old male which had come to us with acute onset painless diminution of vision in the left eye since 10 days with post-trauma with a stone. He was started on anti-glaucoma medications from elsewhere in the left eye because of raised IOP. Patient did not have any systemic medical illnesses as such. The right eye anterior segment and the fundus was within normal limits, whereas the left eye showed a few endothelial pigments, 1.5 millimeter hyphema, and cells in the AC, and multiple sphincter tears and a traumatic mydriasis. The left eye best corrected visual acuity was PLPR accurate with an intraocular pressure of 40 millimeters of mercury. He also had a left eye totally anteriorly subluxated traumatic white cataract with vitreous prolapse in the anterior chamber. The fundus was not visible at all, but the B scan showed that the retina was attached. So he was diagnosed as left eye traumatic subluxated cataract with a secondary glaucoma. He was started on topical steroids and cycloplegics for the same. And he was observed on maximum medical therapy for 2 weeks. But in spite of that, he was having a raised intraocular pressure of 31 millimeters of mercury. So the patient underwent left eye intracapsular cataract extraction with anterior vitrectomy. In spite of that, again, he also had persistent raised IOP for 1 week. That was 40 millimeters of mercury. But the left eye visual acuity best corrected was with plus 10 DS was 20/80. He was having surgical aphakia with some amount of cortical matter floating in the vitreous due to pre-existing PCR, along with disc damage as well. He was kept on medical management for 2 weeks or so, but again he was undertaken for pars plana lensectomy along with secondary intraocular lens implantation after the primary surgery. Here is a post-operative picture of 5 days of the left eye. You can see the stable SFIL in the patient and resolving corneal edema. The visual acuity was 20/200 with an intraocular pressure of 14 millimeters of mercury of any AGMs. But as you can see in the fundus photograph of this left eye, you can see the disc cupping and the normal retinal vasculature. Also on zooming in, you can see multiple subinternal limiting membrane hemorrhages which are scattered throughout the posterior pole and mid-periphery. And also there are a few white-centered hemorrhages which you can confirm on the red-free imaging as well. So this was diagnosed to have an ocular decompression retinopathy in the left eye. The hemorrhages which you can see have resolved over 1 week or so, and the visual acuity remains stable at 20/60. If we look at the pathogenesis of ocular decompression syndrome, there are two theories in literature which you can see, which is a mechanical theory and the vascular theory, wherein the mechanical theory states that there is a scleral prolapse and mechanical capillary sharing which leads to the hemorrhage. Another theory also states that there is an anterior movement of the lamina cribrosa, and because of that the exoplasmic flow is impeded. And lastly, there is an anterior egress of the fluid from the posterior segment into the anterior chamber post-YAG iridotomy, causing a posterior vitreous detachment and a vitreous hemorrhage. The vascular theory also states that there is a fall or a loss of autoregulation of intraocular pressure, and also there is fragility of the capillary vessels which leads to the vitreous hemorrhage and the multiple layered retinal hemorrhages. There are a few differential diagnoses of mimickers which we need to keep in mind, which is central retinal vein occlusion, valsalva retinopathy in particular, wherein a CRVO also shows venous dilatation and multiple tortuosity of the vessels, and the patient is usually symptomatic and the visual gain is poor. On the other hand, valsalva retinopathy can occur in an eye without an ocular iatrogenic intervention, and pre-retinal hemorrhage are usually distributed along the macular region. Ocular decompression retinopathy usually resolves in as short as 2 weeks, and it can take as long as 72 weeks as well to resolve. In most patients, usually no treatment is required, but there are a few patients wherein vitrectomy is required to remove a visually significant or a non-resolving vitreous hemorrhage. Here, the importance of adequate preoperative reduction of IOP is reiterated, and it is of utmost importance. To conclude, ODR, as you can see, is a rare condition occurring due to sudden iatrogenic decrease in IOP, and it is characterized by multiple layered retinal hemorrhages. Usually has a benign cause, good baseline vision is usually retained, and it is post-spontaneous resolution of these hemorrhages. Lastly, adequate precautions to prevent this entity should be adopted during surgery, especially by maintaining a perioperative or a preoperative hypotony. Thank you.
Sure, thank you. Next speaker will be Dr. Khushbu Somani.
Good afternoon, everyone. Today I'll be speaking on the topic that does eye and heart have a common pathway. So with it, starting with rheumatic valvular heart disease, predominantly seen in young age group, accounts for 2% of the serious diseases. So this is a chronic progressive disease which leads to various ocular manifestations, and some of which may be vision threatening, like rod spots, endophthalmitis, BRVO, etc. So, with this, I present you a case of 22-year-old female which was admitted to the cardiology department with complaints of breathlessness, fever, joint pain, and which was already diagnosed case of rheumatic heart disease and was a post-COVID case, COVID-19 case since 2 months. So she was already confirmed on 2D echo, and even on the hemogram, she was a anemic patient. So with this, she was undergoing some systemic antibiotic administration, diuretics and beta blockers to relieve cardiac symptoms. She also underwent a mitral valve replacement surgery for long-term benefit and rapid recovery. With this, patient was referred to our ophthalmology OPD in view of gradual progressive painless diminution of vision in both eyes since 2 months. With this, her right eye vision was 6/36 parts and with improving to 6/24 parts with pinhole. In left eye, it was 6/36 parts, improving to 6/12 parts with pinhole. The ocular examination like head posture, facial symmetry, anterior segment evaluation was within normal limits. So on this basis of diagnosis, we started to think for various diagnoses like, can it be due to rheumatic heart disease like BRAO or hemorrhage involving macular region, or due to COVID like mucormycosis or CRAO, or due to hypertension like grade 4 hypertensive retinopathy or CRVO. So with this, we did the dilated evaluation, and it showed that it had a well-defined yellowish grayish lesion around the macula with surrounding striae with few vitreous cells, suggesting of central choroiditis. So, and with this, we also saw that left eye was normal. With this, to rule out further confirmation, we did OCT, and further investigations like FFA was not done as cardiologists refused the fitness. On OCT, we saw that there were cystoid macular regions in the macular area. So, with this, we started the patient on topical steroids. Systemic could not be started as the cardiologist refused the fitness. So, to confirm the etiology, we did various investigations like contrast-enhanced MRI, CSF lumbar punctures, chest X-ray, sputum, mentox, etc. And on contrast-enhanced MRI, it showed multiple tiny areas involving cerebellar and cerebral hemispheres, also with non-communicating hydrocephalus with periventricular ooze, suggestive of etiology like tubercular. They advised to do CSF study, so there were no abnormal cells present. Further follow-up couldn't be done of the patient as the patient was not financially supporting. So on follow-up on the OPD basis, we saw that after 2 months, patient improved to right eye 6/12 parts and left eye 6/9. And we also saw that there was a decrease in choroiditis on the OCT. So with this, I just want to say that there may be some retinal manifestations of COVID-19 like endophthalmitis, candida retinitis, tubercle choroidal abscess, and also there are many causes of central choroiditis like syphilis, tuberculosis, toxoplasmosis. So I just want to say that rheumatic heart disease is an autoimmune heterogeneous disease, and streptococci being the commonest organism involves the retina, showing rod spots, dot hemorrhages, and also involves macular region due to microembolization. So there may be some link between this heart and the ocular manifestation. So just want to conclude saying that treatment for the central choroiditis is immunosuppression given under some antimicrobial cover, and rarely these central choroiditis like manifestation are sight-threatening and should be early managed and can prevent permanent sequelae further. Thank you.
Sure. Thank you. Thank you all the participants. Thank you.